So, can you describe then the model that you all built at Metro Health? Maybe it's the same model for Medicare, Medicaid, commercial, or maybe describe how they're different. How did you go about building the right model for your context, for those patients in your market?
Few things. First thing first, one is to truly understand if, and we at Metro Health, we count about 300,000 unique members that we're accountable for, that are attributed to us one way or the other. That's on our own attribution logic. That's not a payer logic. When I first entered Metro Health, the only one large value-based contract that they had was that Medicare Shared Savings Program. And the average attribution there is 10,000. If you try to change the care delivery to accommodate for those 10,000, you're bound to fail because you're not going to leave. What do you do with the other 290,000 patients, right? The financial equation and the support and the workflow that is needed to support the 10,000 patient, my example, under a pretty advanced, although it's only upside initially that we were in, value-based program, is completely different than the other 290,000. And when I first came, my predecessors thought, well, we need to move into this patient-centered model of care, and we're gonna deploy all those care coordinators, and they're gonna figure out the care gaps, etc. The problem, the incentives were not aligned. They got diluted in the day-to-day operational model. They get absorbed into the teams and to do mundane day-to-day functionality. And there was not a common purpose to go for, although initially everybody understood conceptually what the model is, but what they were held accountable for is a very straightforward productivity P&L model on the team level. So it was bound to fail. So the first thing we did, we pulled all those resources out of the care delivery. So we went backward, but for a good purpose. We standardized their work, held them accountable, and tried to initially focus them as much as possible on those patients that we were really accountable for their care. All at the same time start to think we can't have a hammer to push with all kind of problems the same way. What I'm trying to say, within that patient population that we're accountable for, we went and identified those who are the sickest of all sick that we can change their trajectory. And we created a special workflow and clinic for them that was fully supported in the model of that you would have in the high capitation and even more because they required that. And very quickly, we start achieving shared savings. Very quickly, we flipped the model into an upside downside risk. And with the model that we proved that once you know who the population is, once you know where to deploy your resources, once you start creating new model of cares that are designed for those patient population, the better outcome you have. And gradually, we started getting more of the contracts and more patient attributed in value-based programs. Everybody is on a different level of that scale, and we start investing into new model of care that are now designed to do that care coordination and address the social determinant of health and etc. But only now that we have larger volume that we start deploying back those resources that we pulled away from the care area and we put a wraparound to demonstrate our success. And as the volumes start going up, we start now redesigning our entire care delivery model and redeploying those resources.
So if I heard you correctly, it was really essential to pull that team of case managers or care management personnel away from the 290,000 that was on the old flywheel of the old model of care, really isolate them, sequester them so they couldn't get polluted, but tainted with the old model, and focus them only on this new model.
That is absolutely correct. And as you grow in your new model, you start spreading them back out into the community of providers.
Is there like a tipping point, a percentage of your overall covered lives where you feel that you could move everybody that direction? I know there's some discussion about that in the literature, X% of your total patient base, and then you can flip.
It's hard to tell. The work so if you look at some of my charts, I'll tell you, I have more than 80% of my patients under some sort of value-based care, okay? But I know from the contracts we have that a lot of those value-based model of care are still not to the level of accountability on the total cost of care. The portion that impacts the revenue is still a smaller portion. So what I like to do, and what the work that I think is going to go forward for us to try to solve to that equation, where you live in both of these worlds. And when you believe you have a substantial portion of your patient population under value-based care, is try to identify practices and try to figure out if there are practices that are designed to take care of very complex patients. And if you can get a formula when you can demonstrate that the volume of those practices are under a value-based contract. So if they are high acuity and the volume of that practice is at a certain percentage, we've not determined yet what that percentage is.
Of covered lives or revenue or both?
Well, you can do it either way, right? I don't know if there is a right or wrong answer, but usually if there are high acuity, and let's say it's a senior care practice. I'm not going to call it geriatric. Let's say it's senior care practice. If a senior care practice and there are very high acuity and there are this subspecialized senior practice, you know that their average spend per year is in the 30 to 40,000, those very sick Medicare patients, versus an average Medicare patient that's in the 10 to 11,000 versus a very healthy Medicare patient, which is the $5,000 to $6,000. So I even trying to figure out, and there are so we build those practices where the majority of the patients are those highly complex patients. I don't need a financial equation to tell me what the total financial dollars impacted in that practice, because I know on the average what it is. And this is by design, this kind of practice that in my mind would require the highest investment in the redesign of the care model, care coordination, case management, and social determinant of health wraparound support. Whereas if I have a practice that is deployed in an affluent community, and if the practice by design attracts healthy individual, then even if they are attributed to a value-based contract, and even if it's capitated, you don't need that much of a redesign on the care coordination and the case management, because they are healthy to start with, and the likelihood for them to need those resources is very minimal. So you can't have this, in my mind, the same model for all. okay, to be successful, especially when you are in this hybrid model. So in other words, I try to, as much as possible, understand the practices, create practices that attracts very complex patient and attracts practices that attracts less complex patients and support them in a different way.
And I think that's intuitive. I want to dive in a little more as I think about, and many of our viewers won't be real familiar with Metro Health. Can you talk about what aspects of the healthcare value chain that you own, that you have direct control, what you contract, and how that impacted how you built your model?
On revenue, 75% of our revenue is from governmental programs. That means 75% is Medicare, Medicaid, or self-pay, which is basically no pay for us. And that leaves us about 25% of our revenue from commercial. Okay, we are a safety net hospital. So also a significant majority of that 75% of revenue comes from Medicaid as well. So that's who we are. But also because so 1/3 of our patients are Medicaid patients. Before Medicaid expansion in Ohio, a lot of those patients were basically self-pay or uninsured. And if we are the safety net hospital, that means culturally, the people and the provider, the nurses that were attracted to this care model are more likely to thrive in a value-based model of care, only if you align the incentive and you support them as such.
Can you describe that a little more? So what makes the right clinician, be they a nurse, physician, other, to help you flourish in the model?
They usually self-select. And even if they don't self-select in the first couple of years after being in that model, and that attrition happens with providers, I saw this not only now at Metro Health, but I also saw this when I was with the Chehade Prompt Medical Group, which was our provider group with Kaiser Permanente in Ohio. Those are providers that, for the supermajority, understood a mission. Let me rephrase this. Those are providers from the get-go are driven by a mission. The supermajority of those providers value the outcome that they see with their patients, the care outcome, and the connectivity that they have with their patients. Those are providers, unless you force them into an RVU model of care, don't want to be in an RVU model of care. But many times we find ourselves forcing them into that model of care because that's where the revenue stream is coming from. And they just don't thrive very well with it. They want to spend a little bit more time with the patient. They want to take their time and following up on the messages afterwards and after hours. Even if that patient is not in a value base and it's not attributed to them, and it's okay if they go and see somebody else and they leak out of the system, but that's not how they're wired. They're not wired, let's just see as many patients today as we need to. They self-select. It's a cultural thing and very difficult to describe other than people self-select for it.
Over time, you've got the hospital, you've got a fully integrated system with your physician groups. Do you have your own insurance also, or is that all contracted?
No, we don't have our own insurance. We don't have a provider-based insurance, but we have a direct-to-employer product that we use a third-party administrator to manage. And we have about 10% of our patients in that model of care. And actually, about 1/3 of those patients that are commercial, that are in a narrow, well, most of that products that we sell for the employer are narrow network product, and most of them are in some sort of a value-based contract, and 1/3 of them are a very advanced value-based contract with a significant shared savings attached to them on the total cost of care.
It sounds like you migrated the majority of your patient lives over to some kind of shared risk.
More than 80%, more than 80% in double models. For all of our Medicaid patients, we are enrolled in a value-based contract with the Ohio Department of Medicaid that has a total cost of care and shared savings, and there are quality metrics and that are gateway attestation for patient experience and services. Now, even having that in place, and for this program, it's not just for the fee-for-service Medicaid. If you're in this program, it's called CPC Ohio. All of the managed care organizations that are the managed care program for the Medicaid in Ohio have to participate if you're in. So they are automatically in. In addition to this Ohio Department of Medicaid sponsored program, we will have an additional value-based contract with each of the payer on top of it. In other words, if I perform better than what was called for the state program, I can even get more. And if there are other quality metrics that a payer is interested in, we also contract for and go after to help them with their HEDIS scores, etc. So we don't just stop. Basically, all of my Medicaid patients are in more than one value-based contract. Now, there will not be double dipping on the total cost of care, okay? If I have a contract with a payer A, and through the Department of Medicaid for that year, let's say I achieve savings and I get an X amount of dollars that is proportionate to that A payer, before the A payer calculate my achieved saving, they subtract what I got from the department. No double dipping is on top.
Well, you can always dream, right?
No, it's not fair, but this is how you approach the payer. And you tell them, we know we are in this program, but guess what? I can even do you better. What do you think?
So can you unpack some of the reporting? You talked a little bit about the quality and HEDIS and other measures. So are they all over the board? Is there any kind of standardization? Is that important?
Oh, data is very, very important. Okay, data is very important. So for our largest value-based contract by dollar value, we have to have the full claims data. So from the Medicare, we're a direct contracting entity now. We obviously get all their claims data. For our largest payer with Medicaid, which basically equate to 1/3 of all of our patient population at Metro Health, we have all their claims data. For our largest Medicare Advantage value-based contract, we have all their claims data. For all of our commercial value-based, which I told you it's the majority are direct to employer, we get their claims data 100%.
But that's being transferred over to you from the payer.
From the payer, yes. Get all that unified under a one main analytical tool through our EMR Epic, Healthy Planet. It's called Cost Utilization Dash Report that we utilize to manage. But even that, we many times go back and work directly with each data set independently with the payer, whoever the payer is, to understand a little bit more detail and nuance about the data. Data is very important. We don't manage it on the micro level. Other than quality and care gap closures, of course, you're gonna go and manage it on the micro level, right? We manage at the macro level. We try to see trend and understand if there are changes in the trend that we cannot account for, is usually where we focus our effort to dive into the data and then go down to the practice level, to the individual provider level if needed, etc. But we usually don't micromanage. We stay high.
So a point of clarification, I mean, this will especially be helpful for the audience. You talked about claims data, but you have said that you mostly are on not on fee for service. So what's in the claims data? Are they zero claims, like encounter data, or what?
Those that we get the claims data, they are all on value-based contract. Okay, so the claims data we get from Medicare, it's our ACO, it's our direct contracting entity.
So people still get paid fee for service at the point of service.
Well, it all depends. For the direct contracting entity, that's the Medicare latest and most advanced value-based program. So we are a direct contracting, we are called global. So we take global and they withhold, but they give you the value of the claim. You know exactly what the fee for service claim would have been.
Okay, so the fee for service part is on paper.
Yeah.
Actual payment is a global.
That's on the direct contracting. And it gets confusing. In the first year, for the claims part, we were capitated directly on the professional and not on the technical. Although when it came to the total cost of care, we were capitated global. So they were not paying us, what they were paying us actually still claim on the technical, which is a large volume when you're a hospital-based system. Although we were accounted, just the way the money was flowing. For this next year, because I don't want to be misstated, it will be both technical and professional, where those dollars will be withheld. But we would know what their value would have been under fee for service. Oh, absolutely.
That's really important because I know I've heard of other models where the actual cash flows on a fee for service basis and the capitation is really just a paper target. That's why I want to.
Well, and we have those, the MLR model that we contract for is basically that, right? You get paid for fee for service, MLR target, medical loss ratio target, and then you reconcile at the end where you are on that medical loss ratio. So yeah, we have both.
Do you see any real difference between them? Can either one be successful? Does it matter?
For me, it doesn't matter. You're accountable for the total cost of care in both models. The only difference that makes is it upside, downside, or I mean, even in MLR, you can have an upside only or an upside downside, right? And even when you are fully capitated, that means $0 on the claim, no one is not going to advance dollars for you, right? The payer has to advance dollars for you. Your cash flow has to be there. They have to estimate what the payment would be for each quarter or each month, and they have to advance the payment. Okay, and then you reconcile. So it's right pocket, left pocket. And perhaps the audience might be under the impression that a fully capitated where it's $0 care delivery will only get their money at the end of the year, or because it doesn't happen even at the end of the year. It would be like 6 months after the end of the performance year. That will be financially not sustainable.
Okay, that's really helpful.
Yeah, your cash on hand will not be looking good at all.
So regardless of which model, and you gave two good examples, the actual cash flow can be negotiated.
The actual cash flow could be negotiated, and it has to. I mean, there's no such a thing as cash flow is only at the end. There's no industry like this, right? You don't go lease your car, you get to drive it a year and a half or 3 years, and after you're done, you go and say, these are my dollars, right?
Right.
Although you didn't buy it, it's you gotta figure out the flow of money.
If somebody was less experienced than you, right, when you're just getting started, do they also need their data people in the room to make sure that these grand ideas are actually?
Oh, absolutely. Otherwise, well, yes and no. As long as it is all upside, but the reality is there is no such a thing that all upside. Very few programs that are all upside. What they don't understand that many times when the contracts are negotiated, even on the commercial, what does the payer want to do year after year and after year? Wants to negotiate to keep their rate down or even take them lower. And then they go and tell you, well, we're going to do this, but there's this other bucket of dollars you can get from doing those quality metrics, et cetera, right? All those other incentives. And then you think of them as all on the outside, because those were otherwise revenue, you are going to get them in the fee for service. They just segmented them and played that trick on you. So what we do, since I am on the care delivery level, I preempt that. And I tell them, okay, this is the average rates that you pay me. I want a 10% more next year. You want give me only 5% more on a fee for service. And we cannot come to an agreement. Well, how about that delta of 5%? Why don't we put those dollars in a value? Let me earn them. Instead of them trying to hide those dollars and play the trick on you, put it all out and be very transparent. Say, this is how we're going to do it. I want a 10% raise. You want only to give me a 2%. There's an 8%. How about we take 4% of that 8% and let me earn it? And we call it a day.
And then we're looking at quality metrics and things.
Quality metrics. It's in Medicare. You can do incentivize on Medicare wellness visits. I mean, there are all kind of, what do they want? What is that the payer is incentivized to do, right? And we do them as long as they provide at the end of the day better care for the patient, better quality outcome, and it allows to enhance our revenue stream so we can build our care management and expand on that. But those are how you start siphoning dollars from the payer and move them into a different model of payment. Do that to you without you knowing it. I mean, dollars don't grow on a tree. They have to come from somewhere when they incentivize you. So when they tell you everything is on the upside, there's no such a thing.
That's a perfect segue to my next question. We're near the end. Talk to us about evaluation. You've got data. You guys are professionals now. You've done this quite a while. How have your models worked? I'm thinking financial results, quality results, experience results, any of those things.
We've done extremely well, extremely well. What I wanted to prove that we started doing extremely well on the Medicare world. Okay, we started achieving saving the first year that we started making the change in 2016. And we've been achieving savings since then, as much as 10%. And sometimes this year on some Medicare Advantage program, we've done even more than that. But there is a little bit of COVID hidden in there that changed the equation. I don't want to give ourselves a lot more credit. So we demonstrated that we could do it in the Medicare population. And we, on purpose, our next area was the Medicaid population because it's a large population for us. And a lot of people have struggled to do value-based on the Medicaid population because there are not captive audience. They tend to move from one practice to the other, and you can't manage them as easily as a Medicare patient. Even if Medicare patient is not in a narrow network, they're more likely to come back and see their primary care physician and stay within their network because that's where they feel safe versus the Medicaid population. By nature, they're all over the place.
It's kind of a health literacy or social determinants.
It's health. It's what's available to them today. They don't know sometimes any better. It's what's available today. And a lot of it is sick care. A lot of it is I start getting my care, OB care at this place because this is close to home and that's where transportation. But hey, I heard this great maternity ward even way far away. And then suddenly I'm going to go and when it's time to deliver, I'm going to show up somewhere else. So it's very hard when you're in value-based contract to make this successful when the patient leakage is so high. So that's why we really moved into the Medicaid population. And we demonstrated that for our size of an organization, we're the lowest cost provider in the state. So we have achieved savings quite a bit on the Medicaid, so we demonstrate that. And our third one was to tackle the commercial. So we start demonstrating the success, and we've been successful on all aspects. Lesson learned from all of this, in my mind, you have to really be careful not to redesign ambitiously all your care delivery model because it's not sustainable. You have to align the flow of revenue from value-based with your redesign of the model of care. And you have to understand what business you're in.
Can you talk some more about some of the quality outcomes? You talked about saving money, 10%.
Yeah. Oh, yeah. Oh, yeah.
What are other measures?
Quality outcome, I say this very loudly. If somebody is accountable for the total cost of care year after year, year after year, not just for a 1 year, over a long period of time, you don't need a lot of separate quality outcome. The care delivery is incentivized to do all the right thing from the beginning, right? Because you want to keep the patient out of the hospital. How do you keep the patient out of the hospital? You keep them healthy, right? How do you keep them healthy? You get them engaged with their primary care doctor. You get them their vaccines,
So you're
right?
saying just with the financial incentive, it drives all those other behaviors.
If it is for an attribute patient population that you're attributed for year after year. If you're doing this stint for a year, and that doesn't work. Then people get the tendency of rationing care and how to game the system. But that is within a year or two, this will come back to bite. I mean, we're seeing naturally this during COVID. All those patients that naturally did not come in and get their care because they were afraid of COVID and because the care delivery was closed, that's what happened. They had to come back later on with a lot more expensive care because they delayed care. So ultimately, it drives itself. Nevertheless, since also a lot of those programs on value-based starts all with quality metrics, your provider, your workflows now are designed to address them. Okay, so cancer screening becomes bread and butter of what you do, whether it is, and the two main ones, the colorectal cancer screening and the breast cancer screening, and for a lesser extent, prostate cancer, right? You start doing those, you start getting incentivized, so you already redesign your workflows. Once you redesign your workflow, you're not gonna go break that because you know the value that comes out of that. It is aligned with keeping the patient healthy on the long run. But if you're only going to be accountable for this patient population for a year and you're not thinking on the long run, yes, perhaps you need separate quality metric on the colorectal cancer screening. I'm just giving an example because those are more long-term goals. So you keep your patient healthy. But hemoglobin A1C, blood pressure, which are day-to-day activities, you're not going to be successful in a true value-based contract, an alternative payment model, if you don't control those. I don't need a metric that incentivizes me on blood pressure control or hemoglobin A1C if I'm truly accountable for the total cost of my patient population, even for 1 year. Because an uncontrolled blood pressure can get to a stroke. And that is a disaster on your dollars, no matter how you look at it. Uncontrolled diabetes very quickly can get very ugly. I mean, those are the things I'm talking. And yes, we've done extremely well also on the quality. That's how we started. That's how you build it. You don't leave one or the other, but with a good understanding that you don't do this to chase a number, although initially you do because that's how you align the dollars so you can do the right thing. But ultimately you do them because it's better care and you keep the patient healthy. And keeping the patient healthy is what should be the equation to be successful under the value-based care.
Makes complete sense.
I don't know why it's so difficult. It's not difficult. It's just living in both worlds. It's the living in both worlds that is difficult. That's why Chehade Prompt is so successful and the VA is so successful because that's the only way they get.
They only live in one world. Yeah.
You live in one world, it's not difficult. Well, it's difficult to still do care, but it's not that difficult.